common hip pathology, okay, to have them supine. And you just want to get a general range of motion first. You want to get a good hip flexion, so relax your leg, okay? And you want to come up and you want to go just to the point where they see their pelvis start to move. Okay, if you come up, you shouldn't crank all the way up here. If you crank it all the way up, you can get 100 and whatever degrees. But you want to go just to see where that pelvis starts moving, and that's it. Anything else is moving over your lumbar spine. Okay, so you want to get that. You want to get a good abduction. Really get to there. Come across. You want to get a good adduction. Same thing. You don't. As soon as that lumbar spine starts to move, that's it. And it's very little. Like you can't go past that, but I can keep on going if I want. Okay. And then coming up, relax. You want to get here. You want to get a good internal external rotation. You can get this sitting first, or have them supine. Okay, get a nice 90-90. Okay. And then come out for internal rotation. Okay. Coming across for external rotation. You want to do it side to side.
And are you asking them to tell you if that hurts? Or are you just trying to?
Yeah. Beforehand you can see.
Ow!
If someone has femoral aspendal impingement, where they're just getting impinged right in the front, or they have a bump on the front of their femoral and neck junction that's going up and smashing into the acetabular. Okay. Any internal rotation or extreme flexion or abduction is going to cause pinching in that area. And if it's gone, the only way they're going to get pain in there is one, whether their cartilage is, articular cartilage is worn down, or you're impinging the labrum. And because if it's not worn all the way down yet, there's no nerve fibers in it, so you're not going to feel anything there. So you want to get a good internal rotation here, and they'll feel that. I'm sure if we look at everyone here, there'll be some people that stop here, and you wouldn't even know. But you have a bony block right there, and over time that may cause injury. So you want to get that. And another way, this is just a log roll test. It's just a quick, easy way to do it. You just come over and how far you can internally rotate. Same thing. As soon as they start coming up off the table, you're done. You do that side to side. And you can do camel grind, where you just apply axial load down into the joint and just kind of move it around.
Is that your pop?
Yeah. Well, it's sideline.
Mortar and
Sideline should compress the head.
And you can remember, if people come in with low back pain, it can also be because this joint is tight, and that they're transmitting force up through their legs, and that hip doesn't have the range of motion. It goes right to the lumbar spine. Oh.
So you saw the straight leg raise. Yep. So patient typically will complain of pain down their leg, which at this point certainly could be from lumbar pathology, from nerve, but it also just could be hamstring tightness. So one of the ways to differentiate that is you ask the patient, let me know when you start to feel it tight, get tight. And at this point we can't be sure the cause, so we're going to drop it down to where they don't feel pain, which takes attention off the hamstrings. And now we're going to elongate the nerve by pulling the foot down. Remember, that nerve path comes all the way around. So by pulling down, we're putting tension on the nerve, which will put tension on the nerve root if it's nerve root involvement. So what you would be expecting to hear is that, yes, that causes pain, and you would say, well, where? Doesn't matter. You don't want it here in the calf so much because you're pushing down there, but kind of shooting down my leg a little bit would be the typical thing. And that's just an easy way to differentiate whether something's just a muscular tightness versus actual lumbar pathology.
And the favor test that she was talking about, also, you can do this motion, and if you have them just plop it there, you can stabilize this side, and just give a little little pressure here. You can get some hip pathology there, but you can also get some SI dysfunction in there. Did you feel that SI joint? Yeah. And another thing too, you can put your hand on your inside your ASIS, both sides, get a little compression for both SIs this way, and then also this way to distract.
In the fibers, you can do two things. You can have them actively do it and just ask them to put their right heel on their left knee, which certainly would test their muscular and ability to do that, versus the clinician doing it, the PA doing it, which would be more passive, might be more indicative of a joint issue than muscular issue.
In acute multi-trauma situation, the open book test and the pelvic compression test, that's it for the pelvic exam. I mean, those are the things you're really looking for. That'll pull out a pelvic injury, even if somebody has multiple trauma.
What about leg length for SI dysfunction?
Well, go into that.
Everyone has leg length discrepancies. You can clinically determine one versus the other. It takes multiple steps to get to true leg length versus pelvic tilt, to identify whether it's anterior, posteriorly rotated. Ultimately, you need a measured X-ray to actually measure the joint lengths. I mean the bone lengths, but clinically it's usually not that important to get to that detail.
And do people have a standard? In other words, is there dominant side, the one that's usually longer or shorter? Is there any relationship with that whatsoever?
The one test that I usually use to see if there's SI dysfunction and rotation is the long sit test, where relax, apply a little bit tension on both legs. Okay, bend your knees up, bridge up off the table. Yep, come on back down.
Sorry.
And now sit up. You're measuring medial malleoli with your thumbs here. And, if they're you're pretty good right there.
So measuring length discrepancy.
And if you're rotated either way, you can have a discrepancy in the leg length. You can have it's kind of a quick way to do it. There's a whole lot of other things going on.
Yeah.
But it can just.
Can you show us that again?
So Randy, are all of those steps beforehand kind of like resetting the leg length so that
You're right.
So kind of, actually what
You're
right now.
bringing the leg into
Well, before you even
discrepancy.
do the test, you want to look and measure the malleoli, because that's going to give you how they're living normally, their functional position. And ideally, they'll be even, but occasionally not. At this point, you know there's a difference, but it's hard to tell where. You can't tell if it's muscle balance, if it's actual leg length, if the pelvis is anteriorly or posteriorly rotated. Then you go into the test that we just showed, which is designed to put the pelvic into a neutral position. And that should eliminate this kind of stuff. So you're going to bend your legs up, just like we showed, push your hips all the way up, and typically you want to hold it there for at least 30 seconds. You want to give the core muscles a chance to pull evenly on the pelvis to kind of neutralize it. So keep holding nice and tight.
There's a whole set of people that you would just never be able to do this.
Sure, so this is typically a younger population.
young
You're not going to
people.
do this with the 70-year-old. I like to have the patients then extend their legs, and you can check and see the difference, and it should be relatively normal, meaning equal. So this should neutralize whatever difference you saw at the beginning. Now what we're going to do, or I like to do, is have them sit up, which don't do it yet. This is the long sitting. So now let's think about this. The pelvis is here. We've kind of put this all in a neutral position. So as they sit up, the pelvis is going to rotate.
Yeah.
If one side is fixed or loose or rotating more, it will demonstrate in the position of the leg. Because as they rotate, the head, the femoral head is going to stay in the acetabulum. If it's more posterior, it's going to be a different length than if it's anterior. So I'm just going to put my fingers again at the malleoli and go ahead and sit up in the long sitting position. And look at that, you're about 1/4 of an inch longer on your left side. And now there's some other things you can do to try to determine, is the right side fixed, causing this side to be more mobile? Is this side fixed, causing this side to be? There's kind of a series of things. But each one of those kind of steps in the evaluation has a purpose that you're trying to demonstrate to get a result. Do you have hip or knee or back problems?
Sometimes back problems.
Who knows?
It's because you weird leg. Yeah.
And what's the name of this procedure?
It's actually a series
It's a battery.
of things.
Yeah.
Like this is the long sit test. You combine it with the two things to identify a side. Then you can get into a whole sacroiliac exercise. Right?
Yeah. That's a whole other course.
Absolutely.
What are the long-term complications of having somebody with like that kind of dysfunctional one leg falling?
If they're not symptomatic, there
I
are.
like to refer to it as a
Everyone, our bodies aren't perfectly symmetrical.
Yeah.
These are only important if you can relate it to some type of symptom that you think you can correct.
Yeah.
So when we're talking about lumbar problems, sure, it could be disc, it could be degenerative problems, maybe it is a leg length. But in order to get to the root and to fix it, you kind of have to find out which one of those it is. Some you can do with diagnostic testing, x-rays, MRIs, but others are more clinically oriented.
Cool. Thanks. Thanks. Yeah.